people may still be filtering in here, but I'll go ahead and get us started here. So hello and welcome to the Medicaid Insights Colloquium, also known as Mike. Thank you all for tuning in today. I am John McConnell. I am the professor and director of the Center for Health Systems Effectiveness at Oregon Health and Science University. And as usual, I'll start by going over a few quick notes for our time together today. So this session will run for about an hour, including 40 minutes of presentation, followed by 20 minutes of Q&A. Because there are so many of you joining us today, we're going to ask you that you refrain from using the raise hand function. And instead, if you have a question during the presentation, you can submit it at any time by clicking on the Q&A button at the bottom of your Zoom window, and we'll get to as many questions as we can after the presentation. All right, I want to take a quick moment to recognize my fellow members of the Mike Planning Committee for their continued work in planning these events. Jamila Michener is an associate professor of government and public policy at Cornell University. She is the co-director of the Cornell Center for Health Equity and co-director of the Politics and of Race, Immigration, Class, and Ethnicity Initiative, and board chair of the Cornell Prison Education Program at Cornell University. Jamila is not here today, but Will Shapiro is, and Will is an assistant professor in the Division of Health Policy and Economics of the Department of Population Health at Cornell. Sorry, at Cornell, lost my intro there. Sorry, Will, but most of you know Will, and Will is our the other person in our planning committee. So, oh, sorry, here it is. Got it. At the Weill Medical College of Cornell University. All right. So now I have the pleasure of introducing our featured speaker, Dr. Emma Sandoe. Emma is the director of the Oregon Health Authority's Medicaid division, and we're in Oregon right here, so I'm excited to have her here. Before joining Oregon, which was a big deal for us, she served in North Carolina's Medicaid program and served as the deputy director of Medicaid policy. In her current role, she has been the state's primary liaison to the Federal Centers for Medicare and Medicaid Services, CMS, and overseen the state's Medicaid plan and Medicaid waivers, and taken a lead role in developing and implementing new policies in the states. She was instrumental in many of these efforts in North Carolina, including implementation of the state's Medicaid expansion. Emma got her PhD in health policy political analysis from Harvard University in 2019 and an MPH from George Washington University in 2010. Before joining North Carolina's Medicaid program, she worked as a press secretary at CMS and budget analyst at the U.S. Department of Health and Human Services. So she has lots of great experience and perspectives. I said up at the front that we were just so excited to have to learn that Emma was coming to Oregon. I think we're in Oregon where we have the Trailblazers, which is kind of a mid-market team, and landing Emma at our Medicaid program felt a little bit like having LeBron James or your athlete of choice come to join the Trailblazers. So a lot of excitement here. So that's Emma. We're excited to hear from her. She's going to talk about her experiences in both North Carolina and Oregon. So please join me in giving a warm welcome to Dr. Emma Sandoe.
Thank you so much. I think this is the first time I've ever been compared at all in my entire life to LeBron James. So I am just so excited to be here and back home on the West Coast, which is a theme for today, talking about moving from coast to coast. And I am currently in Southern Oregon, very close to this picture here. It's an absolutely beautiful place to live and be. So if anyone wants to work for Oregon Health Authority and the Medicaid program, I will make sure you know how to get a hold of me as well. This is also an opportunity to recruit wonderful people to our beautiful state. But I am about to share my screen and talk to you a little bit about my time in both Oregon and North Carolina. And I believe I may be one of the first Medicaid directors that has talked to this group. But I'm not the only Medicaid director that has a passion and love and interest in research. There are several Medicaid directors currently serving with PhDs who are all very excited about the work that academics do and the connection between Medicaid policy on the ground and operations and evidence-based research and in the ways in which we can ensure that our programs meet the needs of the people that we serve through evidence and research. So I'll touch on that as a little here and what it means to be a Medicaid director and the role that we play. So you've probably all heard many times that once you know one Medicaid program, you will know one Medicaid program. But about 9 months ago, that became so evident to me as I transitioned from the role of Deputy Director of Medicaid Policy in North Carolina to Medicaid Director in Oregon. While the states are look very different, there's a lot of things that I've learned are so connected and so similar at the same time. So while this is a commonly used phrase in Medicaid parlance and conferences and webinars like this one, I would challenge that it's not entirely true. There's a lot of really important lessons learned from state to state, and going from state to state has been an exceptionally wonderful experience that I've had to bring what I know from another state, but as well to really learn and grow the team and the staff, because we can all learn from each other. And really good policy is learning, growing, and developing state policies from state to state as well. So I'm sure you don't need me to tell you that Oregon and North Carolina perhaps can be viewed of as polar opposites in many ways. I certainly have heard that often as I've transitioned, that people have been surprised that I came from North Carolina to Oregon. The differences between the states are numerous, with the size of the states in terms of the population. In Oregon, we have 4 million people. In North Carolina, it's about 11 million individuals living within the state. What that means in terms of how many people are enrolled in the Medicaid program, it's about 3 million in North Carolina and about 1.4 million in Oregon, so about double the size of the population in North Carolina that are enrolled in the Medicaid program, but a smaller portion of the state population. The politics of the legislature look very different between North Carolina, which is a Republican-controlled legislature, near supermajority, and Oregon, that has a supermajority democratically controlled legislature. So a lot of the bills and work during legislative session look very different between the two states. The role in which the managed care plays in the two states, which I'll get into a lot more detail, on the face of it look quite different, with the North Carolina only recently moving to managed care from a historically very fee-for-service focused Medicaid program, and Oregon, where managed care has been part of the model for a number of years. The Medicaid program itself, and this has been one of the most interesting parts of the distinction. In North Carolina, it was pretty centralized within the Medicaid agency. The Medicaid agency had a lot of the functions within the Medicaid agency, from long-term care to a lot of the behavioral health services, and all of the different parts of the Medicaid agency were housed under the Medicaid team. Whereas in Oregon, and this is true with a number of other coastal states on the West Coast and to some extent on the East Coast, it's really diffuse throughout the state government. So with Oregon, our sister agency, the Department of Human Services, runs our long-term care programs, and then similarly, a lot of our other programs are run in different parts of the state government, using Medicaid funds, using Medicaid authority to run those different programs. Ultimately, the decisions I do sign off on, so I am involved in all those different interagencies, but it's a lot more interaction with partner agencies and partner portions of state government, which is unique to a number of states, but not certainly not alone. In North Carolina, a lot of eligibility was run through the 100 different county eligibility workers, whereas in Oregon, the eligibility systems are really centralized, with the centralization also really intertwined with some of the other benefit programs that the state runs, for example, SNAP and other services. And as such, a lot of that eligibility workers and eligibility functions are within the Department of Human Services as well. So it's a lot of interaction with our partner agencies. In North Carolina, when a new service wants to be developed, it's largely the decision occurs within the department and within the Medicaid agency, whereas Oregon has a unique model known as the Health Evidence Review Committee, or HERC, which makes coverage recommendations based on evidence and based on review as part of Oregon's long-term 1115 waiver and the decision-making around coverage decisions there. So in the face of it, very, very different states, but purely based on the next two slides that I'll show you, and I love a map, so I will illustrate with maps of our states. They actually look a lot more similar than meets the eye. So this is our enrollment by county, and as you can see, some of our rural, poorer portions of the state, we have up to 50%, 51% of the population within those counties enrolled in the Medicaid program, whereas some of our urban cores and urban centers of the state in the northern portion of the state, it's about 1 in every 3 people are enrolled in the program. But those are where the people ultimately live, and sort of looking similarly in North Carolina, the population centers do have a higher proportion of the enrollees, but in the rural areas of the state, if you were to look at it as by population, you can see again that it's high numbers of people enrolled in Medicaid in those rural, lower income portions of the state. So both states have urban cores with a lot of space for rural issues and rural communities that have high poverty levels and high Medicaid enrollment. And so that alone is a really significant relationship between the two states. North Carolina actually has the highest rural population in the country, and similarly, a third of the population in Oregon is rural. And so those dynamics of ensuring that the Medicaid program, who's often the primary payer in a lot of those rural communities, is addressing the needs of the high number of people that live in those areas and depend on the Medicaid program. So other similarities, North Carolina and Oregon's 1115 waivers, which I'll talk about in a minute, look very similar to one another. North Carolina technically started first in 2022 with providing housing, nutrition, transportation, and interpersonal violence services through the health-related social needs programs. Oregon began implementation of similarly a focus on housing, nutrition, and air filtration and other devices to assist with high impact effects of wildfires and other extreme events, as well as community capacity building in 2024. I'll talk a little bit more about how those all work. But we in Oregon went statewide to begin with. And that is a significant difference from North Carolina, which had pilot regions. Managed care began, as I mentioned, in North Carolina relatively recently, but it's not actually that old of a model in Oregon either, with the launch of the CCO program, the Coordinated Care Organization program, beginning almost 14 years ago now. Both states are what are known as M-CHIP states, so meaning that it's a Medicaid expansion of the CHIP program, and both have done this within the last 2 years of converting to an Medicaid expansion from a separate CHIP model. That seems to be the more it seems to be happening more and more. States that initially set up separate CHIP programs are realizing that there's efficiency that is gained in creating, putting them all together into a Medicaid expansion CHIP model. And that is interesting that both of the states did that so at relatively the same time. Of course, now both states have Medicaid expansion to cover adults up to 133% of the federal poverty level. But of course, Oregon was one of the first states to adopt this change, doing so before the Affordable Care Act implementation through a pilot program, and North Carolina, one of the latest states to adopt Medicaid expansion. Both states have implemented continuous enrollment. Oregon was the first to receive a waiver to provide continuous enrollment for children ages 0 to 6, and then also provide continuous enrollment for adults and people over the age of 6 for 2 years. And North Carolina was one of the most recent to get similar authority through the 1115 waiver. But what I want to dig a little bit deeper now into is the approach that both states took to unwinding. So I came out to Oregon about 9 months ago, which was still in the midst of unwinding. We completed all of the unwinding processes about a month ago. But both states have been vying at various points for the top in the nation for their approach to the unwinding, with taking beneficiary-focused approaches to ensure that people remain covered through Medicaid in the unwinding from the COVID-19 pandemic. And the ways in which they did that was really similar to ensure that people either were, if they were still eligible for services, continued to be enrolled in the Medicaid program, or that they were transitioned to the appropriate healthcare program if they were no longer eligible for Medicaid. So I was trying to be fair to my former state here by picking one of the places where North Carolina actually had a higher rate of renewals compared to disenrollment rate for according to the Kaiser Family Foundation unwinding metrics. There are several other places where you can see these flipping back and forth, but really Oregon and North Carolina are stand apart from many other states, in part because both states launched new programs in the midst of unwinding to ensure that people retained healthcare coverage. In North Carolina, the Medicaid expansion was launched a few months into the unwinding process to ensure that people who would have otherwise lost coverage and may have their children may have aged out, so they were no longer eligible for parent caretaker eligibility. They retained coverage by moving to the Medicaid expansion group, or they themselves might have aged out of child Medicaid coverage and at one point during the COVID-19 pandemic, and then they retained coverage through Medicaid expansion. In Oregon, we actually launched two programs to ensure that people retained coverage. One was the expansion of the Healthier Oregon program, which provides services to people that don't meet the various immigration requirements for 5 years of eligible citizenship or immigration status. Or but would otherwise be eligible for the program, as well as what we call the Bridge program, which provides services to people that are making between 100 and 33% of the federal poverty line and 200% of the federal poverty line. So instead of providing we're moving those folks over to the federally facilitated marketplace, and they getting help with their premiums and through tax credits. We provide essentially Medicaid lookalike services, so still no premiums, still no copays, and a very similar set of services provided to those people that may have gotten a job to get higher income, and so those people transition to services that look very similar to Medicaid rather than the marketplace. And so those programs helped maintain a lot of people in health insurance coverage following the unwinding, but we also really relied on technology to first check all of our available data sources instead of reaching out to people and requiring them to fill and complete paper applications or paper renewal forms. We first checked all of the available data sources, and that really alleviated a lot of burden both on the state as well as on the individual. So I think it's important to note that operational detail of that alleviation on the state and the state workers, because then the state workers were able to focus more of their attention on complex cases of individuals that may be eligible but need more time and attention from those eligibility workers to ensure that they understand the rules of the program and all of the various aspects of what they need to prove in order to remain eligible in the program. And so ex parte and using data systems available to the state helped do that, as well as the continuous enrollment, particularly for kids, that made it so that the state didn't need to do redeterminations on children as I often did prior to the pandemic, and those redeterminations on children were often time intensive for the staff, but the value that received out of the redeterminations was really quite low because unfortunately in the United States, particularly families with young children remain eligible often at a higher rate, and because they stay in poverty due to a lot of additional expenses and limitations for young families that mean that those families stay in poverty oftentimes and thus eligible for the program, but those barriers to continuing to receive health coverage oftentimes are significant. So I will talk a little bit more about churn. So what we did is look at both in North Carolina and in Oregon, look at the ways in which churn particularly affects children and the ways in which people often will come back to the Medicaid program at a regular rate because they remain eligible if they have lost coverage due to administrative burdens and administrative reasons. Maybe they moved their address and then they have a regularly scheduled pediatric dental visit or a regularly scheduled pediatric well child visit. And they come back and realize that their enrollment had been in Medicaid had been terminated, and so they will often re-enroll at that point, or if they need a medication and at their regularly refill days, and so we see that the cause of this churn is largely due to administrative reasons because so many people are coming back so quickly. So we worked with, in North Carolina, researchers at Duke as well as Novi Sci to put together a series of papers actually prior to the unwinding period that looked at the churn rates and how various populations will come back onto the program often over the course of a multi-year period. And this showed that the barriers in enrollment and eligibility are often quite significant. I pulled up a little PDF here of the one of the papers, but there's quite a number of ones I did looking at the individual types of populations as well as some of the health impacts that these churn has on folks. So the continuous enrollment that we implemented in Oregon and is being implemented in North Carolina as well has taught us a lot of lessons already, but there's a lot more that we're hoping to learn from this. We learned that the redetermination process and having regular renewal periods of even annual, but sometimes states have even shorter than annual, does create a significant burden for both members as well as an administrative burden on state and state workers to track down different pieces of information and ensure that different rules and policies are being adhered to and all of the other requirements around the redetermination process. A lot of key health measures for children in particular do rely on continuous enrollment. So as I mentioned, well, child visits are one of the key measures that we have for pediatric health. And ensuring that children are coming back to those regularly scheduled and key marker appointments relies on the fact that they will have health coverage to pay for those exams and pay for those appointments, as well as potentially care management and care support from their managed care organizations to ensure that they're coming back to those visits. And with gaps in insurance coverage, we could see reduced quality of care and adherence to those child visit regular appointments. There are lots of different methods to ensure that we have accurate information and that we are not continuing to maintain people on the rolls. Ensuring that we have the most accurate information is a constant area that we're working to improve and make sure that we are we know what data we are using and using that appropriately for members. I talked a little bit about the churn issue, and that's one thing that we're hoping that will come out of our 1115 waiver demonstration is really a focus on how the coverage from 0 to 6 has reduced churn and had those associated quality measures and health effects. But we're not quite through with our 1115, so more to come in that space of some of the results that we will be seeing. But that's something that we do hope to see. And then I did mention earlier that the fact that we don't need to have folks spending as much time on those cases where we know people are continue to be eligible or should continue to be eligible. The eligibility workers in the state is able to dedicate more time and resources to some of those more difficult situations and provide that capacity and support to populations that have additional complexity. So I'm going to touch a little bit on the different ways in which the two states have approached managed care. And why I have three maps here is that the models are very different in one large way. So in North Carolina, the managed care way in which it's provided is really divided into two main types of um, uh, managed care systems. First is what is known as the standard plans, and that is largely to people that have our children, parents, people with not a significant complex behavioral health needs. They may have behavioral health needs, but it's not necessarily the primary diagnosis or as complex. And that is the majority of the population that is enrolled in Medicaid will be enrolled in one of the standard plans. And there's well, it looks regional based on the map that I provided here. There are actually four statewide plans and one plan that is only located in regions 3 and 5 that provide care sort of across the state or in those particular regions of the state. And then there's for people with behavioral health as primary diagnosis or additional complexity with their behavioral health needs, they'll likely be enrolled in what are known as tailored plans, which provide managed care services for both physical and behavioral health to people based on the region that they live in. So if you live in, say, the green area of the state, your option is Trillium, the green provider in that state, and et cetera. And that's a little bit more similar to the way in which the Oregon model works, where we have 16 coordinated care organizations across the state, and they're regionally focused. So except for some of our metro areas where there may be two coordinated care organizations overlapping in the region, for the large portion of the state, the region that you live in is the choice of CCO that you have, coordinated care organization that you have. And but the difference between these two is that in Oregon, there's only really the CCO model for managed care services. And so people with complex behavioral health needs are served in the same CCO in the same capacity that people without complex behavioral health needs are served. And so these models are quite different in the ways in which they're set up, but there are still quite a number of similarities here. One of the main similarities between the two is really the focus on care coordination and really making sure that people are receiving the primary health services that they need and the behavioral health services that they need, ensuring that we are having flexibility to provide whole person care through a variety of different flexibilities outside of the 1115 waiver. There are a lot of different ways that the managed care or CCO services ensure that people are receiving those wraparound services and those wraparound cares that they may need. I do want to touch on the fact, though, that in both states, There is still a significant portion of the population that is fee-for-service. So here's Oregon's example. We have 7.5% of the members still in the fee-for-service arrangement. And this is we carve out home and community-based care services, but their physical health services may still be provided under the coordinated care model. But people that are enrolled in fee-for-service are a very important portion of our population, with American Indian and Alaska Native making up a large portion of the population. Also, youth that are involved in our child welfare system may receive a number of their services through our fee-for-service program as well. And people that are enrolled in Medicare and Medicaid have a lot of complexity with their needs and the way in which the Medicaid program works with people who are dually eligible. And so fee-for-service still remains a really important program and a really important driver. So we never want to forget that fee-for-service exists. And in North Carolina, similarly, American Indian, Alaska Native people are given the option to remain in fee-for-service, as well as a lot of people with those complex needs around home and community-based care and long-term care services. So I talked a little bit about how we are working with our 1115 to provide whole person care and wraparound services. And I just want to note that we really see the 1115 waiver is filling some of the puzzle pieces, the gaps in our healthcare system. And so we have a lot of different things that we are working through in our 1115 waiver beyond just health-related social needs. We have the continuous enrollment. We also provide additional services to young adults up to the age of 26 who may age out of additional Medicaid services. Which I believe is the first in the nation program, and we call it YSHN, Young Adults with Special Health Needs. We also are working on our reentry program to provide services to people that are reentering the community from an incarcerated setting, and our tribal healing practices, which I believe we are also first in the nation to implement tribal facility practices or services that provide traditional healing to tribal members. But the health-related social needs is not the only way we provide some of those services that are needed outside of the four walls of the healthcare system. The health-related services is another program that we've had for many years, which provides some flexible services such as food or other tangible things, as well as support community services and the community programs to meet members' health needs. But there's also another program called SHARE in Oregon, which provides it's outside of the HRS. So we have a number of different acronym programs that exist, but SHARE and HRS have existed for quite a number of years, and that allows our CCOs to provide certain services to our community and community organizations. And actually today, as I'm sitting here in Southern Oregon, I actually toured a facility that is a primary care clinic that provides a lot of opioid use disorder treatment and services to pregnant women in the community. And they actually have use those SHARE funds to buy a building next door that has apartments for people that are waiting for residential behavioral health treatment. And that while they're on the wait list for those services, they're able to get care and then eventually be placed in the residential facilities, or or the care they needed was lower level care than residential care, and they're able to go back into the community. And that was just so wonderful to see a creative way to ensure that people are getting care where they need it, and then getting the appropriate care at the appropriate time, rather than what was happening before, where people would be housed on the street and potentially have serious health needs, and maybe go to the emergency department, or die on the wait list while trying to get other needed health services. So it's really wonderful to see in it being actually implemented in communities and the lives that it's affecting. In North Carolina, as I mentioned, the pilot regions throughout the states, which I understand are expanding over the next several years, have been providing services through housing, transportation, and interpersonal violence. And one big difference between the approach that North Carolina and Oregon are taking is that in the North Carolina model, there is a sort of intermediary for the pharmaceutical nerds amongst us. You can think of it like a PBM that connects people to the services, connects people to the community organizations. Whereas in Oregon, the CCO plays that role, is connecting the community organizations to the individuals that need the services. So those are two different approaches that states have taken, and particularly the two different HRSN models. I have two more slides. I'm going to talk really briefly about the difference between working in the state government versus the federal government from my perspective. You can probably talk to a whole lot of people that worked in both settings, and they'll provide different viewpoints, but as somebody that has worked in the federal government before, I think you can't understate the importance of operations at the state level. So when looking at a new policy or thinking how to solve a problem, the first things that come to mind is, can we actually do it? Is the systems and datas and tools available, or is that going to be a 3-year, multi-million-dollar IT system change that is just not feasible? So look when examining policy solutions that may make sense in sort of a academic perspective. At the state, the first questions you're going to ask is operational in nature, oftentimes, because operations are so focused, or so much the focus of state work. At states, there is a significant limit on staffing. You never have enough people to do the job, and oftentimes you have one person doing 8 jobs or 10 jobs or 15 jobs at the state level. Not to say that our federal partners at CMS and other places are overwhelmed with staff. I know that oftentimes there are at the federal level people doing multiple people's jobs, and significant limitations on staffing. But it's even more acute, I think, at the state, where you just have so much additional limitations, both from a budget perspective and the ability to recruit folks to come work for the state. Oftentimes our federal partners or congressional folks may have a policy come down, or a policy comes down from wherever it may come, and folks think that there's that every state will implement it the same, but there's actually quite a lot of flexibility within the specifics, and that's a really exciting place to be. Like, as you're implementing a policy, once you get down to how it will actually work on the ground, there's a lot of different pathways you can take, and a lot of different ways in which you can design something so that it works really effectively, and that's something really cool to participate in at the state level. I'm meeting with local partners and people that are served by the Medicaid program on a regular basis. And not everyone that works in the state necessarily gets that opportunity that I get, but it is so amazing to know that the programs that you worked on, the things that you helped build are helping actual people on the ground, and to meet those people and to hear their experiences, as well as to hear the barriers and challenges that they face. Because oftentimes that's a pretty quick fix. Sometimes it's an incredibly complicated fix, but there's ways in which we are able to make the lives of the people we serve better, just through hearing their stories and hearing the ways in which they interact with the program and the ways that they want to interact better. And that's why I come to work every day, is for the members that we serve and the ways in which we can make their lives better. I would say that the people that you hear from at the federal level is very different from the people that you hear from at the state level. And we often talk about trying to ensure we're not always listening to the loudest voices in the room, but who the loudest voices in the room are vary quite significantly between federal and state. As the people on the ground and the communities on the ground at the state level are so different from the federal perspective. And then I probably should have ended on members rather than technology, but I can't understate how when you work for the state, you will somehow also become an expert in IT and technology and the limits of technology, because oftentimes being a policymaker, there's a view that you could just connect IT systems, and my goodness, it is complicated. So technology plays a really important role in state, but it plays a little bit less of a role at the federal level often. I've got some examples here of times in which partnerships with research have worked really, really well. So the Duke Governor's Council on Healthcare Coverage is one really key example. I credit it to being a really big catalyst in the state expanding Medicaid. I can talk all about that for a long time, but I won't. But data sharing between universities is another example of times at which universities and states have worked really well together. When researchers make direct policy recommendations that are things that states can actually implement and do, that makes it so much easier to take the research and turn it into action and change and affect people's lives. And the State University Partnership Learning Network is a wonderful place in which that often happens through Academy Health. And the gold states here are the states that participate in that program with their university partners. As somebody that worked closely with university researchers, I'll take this opportunity to give some free advice of how to work well with policymakers at the state level. First, find the nerds that work at your Medicaid program, because there's plenty of them, and ask them where you can present your research to them, because there are many opportunities where people would like to hear. Engaging with people in real life in 3 dimensions at conferences, and connecting with them in person is always so incredibly helpful. Invite them to conferences. They certainly would love to be included on panels and provide that operational and real life experience that we have to implement some of the research questions you all are asking. Talk about the research questions at all stages along the process, because oftentimes state folks will have a lot of information that they can share. And then I'll just note that data is everywhere in the government. You just have to have a navigator to show you how to use it and how to use it better. So that is all I had, and I think I think that there are already some questions coming
Yeah,
in.
that was great, Emma. You got some incredible experience here, and so yeah. So there's two questions, and I want to answer the first one and then give you the second one. So the first one says, curious if anybody has had experience joining Suplin. Suplin it seems to be a closed group of universities, and if yours is not already in it, I'm not sure how to support that important work. I guess I can say your name because it's on here. Erica, if you want to send me a note, I can respond to that and then sort of connect you with the group that runs that. I think that is a good question, and I don't have a direct answer here other than we're part of Suplin, but I think they don't want to be exclusive, but there is some kind of there are some arrangements where some universities have connected directly with Medicaid agencies, so I can try and give you a little bit more detail and help out there. And anybody else who's interested can send me the same email, and I can connect the dots there. But let's focus on Emma. So here's one question for you, Emma. This is from Addie Coleman. When I was working with North Carolina Medicaid, I know there were some issues with delays in Medicaid coverage for individuals re-entering communities from incarceration, which is particularly dangerous during such a vulnerable time. Is there anything Oregon is doing or has done when it comes to reentry to ensure timely care for these individuals? The answer is yes, and you can explain what we're doing.
Yeah. So there are a number of things that we're doing. I think first and foremost, shortening that window of somebody uh, who's leaving an incarcerated setting to actually getting care can be done either on the after they leave side with more connections into of coordinated care organizations, making that getting referrals in place, getting care started, and that's something that we've been working with our coordinated care organizations on for a number of years to get closer care and those appointments sort of immediately. And then there's the before somebody leaves the incarcerated setting, which first is that the uh, we have a 1115 waiver authority that we're working to implement that would provide services to all individuals up to 90 days pre-release for certain services, just for certain services like medication for opioid use disorder, care coordination services, pharmaceutical services after they leave, et cetera, and making sure that people have all of those sort of care plans set up. But there's also a federal initiative requiring all states to implement essentially a similar thing for children and what Medicaid views as children, which is oftentimes children up to the age of 21 or youth up to the age of 26. If they're a former foster youth, which many former foster youth are involved in the criminal justice system. So all states will need to be implementing that, and that allows for the services pre-release or immediately upon reentering the community. It is undoubtedly the most complex thing that the Medicaid program has entered. And I say that as a state that's implemented housing services. And that is probably the second most complex area that we've recently entered because all of this is just new areas that Medicaid had previously not been and isn't not used to the ways in which Medicaid traditionally runs. So Medicaid has had to be flexible, and that is just so incredibly hard. And the IT technology alone, that's one reason why I put it on there is just such a huge burden to implementing the programs.
Great, thank you. Okay, yeah, I want to take another question here. This one's from Marissa Domino, and I want to tack on something that Will sent to me separately. That's kind of in a similar vein. But so her question is, well, she says, "Great talk. I agree. What are some of the Medicaid features you have experienced that have the largest effects on Medicaid members, however you want to define large, that you might recommend to all states?" And then this question from Will, kind of going back to you had the research slide there. Can you give an example? You mentioned a couple kind of groups you work with, but an example of a impactful direct policy recommendation made by a university research team, just so you said those are helpful, but kind of giving an example or two would be great.
Yeah, so I think one one that's just on the top of my mind, and it's hard to point out any particular things that have like direct or like is the biggest effect on members because there's just so many things that I could point to. But top of mind, peer supports and the way in which peer supports help with behavioral health needs. It has been a lot of evidence-based research, and there's historically have been limitations on the ways in which Medicaid can pay for that. And as we've entered the traditional healing, traditional care worker, peer support, and doula models, having research support the ways in which that care works and the limitations that should be placed on that care to make sure that it works has been so incredibly helpful for it entering that new space of different types of providers of care that we did not always know what the evidence was and whether we were paying for something that may or may not work, but having the research guide us with the specific policies around this is when it works and this is when it may not work as well has been so incredibly helpful for that in-depthness that we need to implement rules.
Great. Okay. I want to ask a question about HRS because you've kind of had a view of this in both states, and uh, I think Oregon's got a long history of this. It's a little bit newer in North Carolina, but clearly, a pretty innovative way that they implemented it. So, what do you want to share? You've got an audience here of 130 people. Are there big things that you want to share here? I mean, I guess we're asking for like, how do we fix Medicaid? Those are big questions. But in Oregon, there's been tension between flexibility versus do things need to be defined more so that plans don't get rejected? Do you use a kind of ad hoc, semi-ad hoc flexible services type of arrangement, or do you use this new HRSN benefit that I think one person said, well, we all know how the benefit works, and so that they had greater comfort from that. I think these things, we hear lots of great anecdotal evidence about these things, and you had one, but they've been hard to really evaluate and understand like where the big picture is here. So you've got a good audience here, lots of curiosity. Are we pushing these things too far? Do you want to keep pushing them? Are there, what's your kind of professional take on these types of things, and what others should know, and where we should push them or not push them?
Yeah, I think unfortunately, for your all jobs or researchers' jobs, I think the best thing that we can do is to ensure that when addressing some of the most complex situations in people's lives is we can't have a tool that we think will work for everyone. We need a toolbox that's filled with whatever specialized tools a person will need. And unfortunately, that means that it's going to be a situation where in order to address the needs of individuals, we need to braid funds, have different pathways and opportunities that would meet each individual situation to the best of the ability, which is like that would be the ideal scenario. However, we have not fully figured out all of the different tools that are required, and the problem with having a really large toolbox or set of tools is that then that means that everyone that is using those tools needs to be trained on how to use the various different tools, needs to have the space and time and ability to house all the different tools in their toolbox. And again, the IT technology systems in place to interact with those tools, et cetera. And so we're still at the very cusp of trying to figure this all out. but I don't think that there's any one panacea in anything related to healthcare. And when we start to expand outside of the four walls of our healthcare system, it's even more true that we don't have a miracle one policy solution. And so trying as many different things as work, we need to know that sometimes it will work in one community and won't work in another community. And that's the complexity of all of this.
Yeah. Okay. That's great. That's a good, honest answer there. So, okay. Well, that's all the time we have questions for here. I think, we could, people would love to pick your brain on lots of these things, but it went fast. So thank you again, Emma. Really great. Thank you to everybody for joining us today. We'll send out a 2-question survey about this session so that you can help us make this program better. If you could answer that, that'd be great. And then our next one is Wednesday, June 4th, and we have Ann Dwyer from Georgetown University Center for Children and Families at the McCourt School of Public Policy. She might be a name you know less, but I have worked with her and talked with her, and she is an incredible source of information and will tell you all sorts of things you didn't know about Medicaid. So highly recommend it. She's going to come in and try to read the tea leaves or tell us what's been happening. So it's going to be a very sort of live, real-time kind of understanding of where we are with federal policy, which is kind of a big question for anybody interested in Medicaid. Okay, don't miss that. Make sure to stop by an RSVP at the series website, and that's MedicaidInsightsColloquium.com. Thank you, everybody, and have a great month. And thank you, Emma. So great.